spend some time talking about those. And as this group asked us to, we intend to kind of finalize and put forward some group of these recommendations. We're not sure if we can get it by the close of business tomorrow, but we were hopeful that we could finalize at least the first initial. We know we have 2 more meetings on the books, but we wanted to promulgate and get some recommendations to some leadership throughout the state of Connecticut, at least early next week. So thank you, Jeff, and I'll turn it back to you.
Okay, great. I will in turn turn it over to Carl Schissel.
Thank you. Good morning, everyone. And thank you, Jeff and Tim, for accommodating my request for an update. I'm Carl Schissel from the Connecticut Hospital Association. I'm Senior Director, Regulatory Advocacy. And I wanted to also invite Dr. Frank Fortunati from Yale New Haven Health to comment as well, because I'm not a clinician. He is, and he has been intimately involved in the daily and perhaps even hourly activities related to trying to address this immediate crisis situation. And I'll be brief. As we mentioned at our last meeting, having learned through the first surge of the pandemic, the importance of collaboration and cooperation among public and private entities, hospitals elected to re-engage something we call our incident command structure, which involved the convening of daily huddles among our hospitals to talk about issues of common interest. In this case, how to address the influx of children with behavioral health disorders into our emergency departments. And the good news is, when you bring people together with a common purpose, they commit to offer creative solutions, but also their resources and energy to address this problem. And by virtue of our coming together on a regular basis, we've been able to work through some efficiencies to achieve patient transfers when needed. We have moved successfully several patients, out of congested settings into, more appropriate settings, taking advantage of available beds wherever they may be. The channels of communication, among the hospitals are open, and we are seeing a level of cooperation almost matching what we had to do during the first surge of the pandemic. We are united in a common purpose and mission, and are happy to report that we think we are relieving pressure on institutions that have borne, the brunt of this work, most notably Connecticut Children's and Yale New Haven Health's Children's Hospital. And I think every hospital in the state is engaged in some manner in this daily work. While hospitals have been convening on a daily basis, CHA, as their representative, has been reporting daily to the state of Connecticut through the Office of Policy and Management and the Department of Public Health and other departments and agencies, including, I believe, DCF, in order to make sure the state is aware of what we're trying to do in real time and immediately to address the situation. So I don't have data for you, and I know this is a short meeting, so I'll stop talking there, but perhaps invite Dr. Fortunati if he's interested to comment on his experience with the incident command structure.
Thank you, Carl. I think the experience, with the hospitals coming together, particularly in the Hartford region, and dealing with the crisis that Connecticut Children's faced was really exceptional. And what's come to light, and I know this is a children's group, but there's equally, or in many ways, greater crisis on the adult side, and we've launched a separate group on the shoreline to help deal with the adult crisis. I think, pulling us the crisis, pulling us together, and there was we changed the Hartford system and CCMC, I think, really changed the way they do manage referrals, and that is and did things thinking outside the box, and we're able to move some patients, and that was terrific. And it's unfortunate, sometimes it takes a crisis to make that change, and we hope we can replicate that a bit on the shoreline with the crises that we see here. But it does, in my mind, bring up that there is I think vastly underbedded in the short term, and I think every possible solution should be put on the table.
Thank you, Dr. Fortunati. So I'll close by saying that, it may be worthy of consideration for us to include among our recommendations an acknowledgement of the willingness and ability of providers to come together in mechanisms such as the incident command structure to address whatever crisis in healthcare occurs, particularly in the behavioral health area. But as Dr. Fortunati mentioned, we've got a problem in the adult area as well with children and adolescents. It's just volume of patients, staffing, et cetera, et cetera. But in terms of short-term solutions to a crisis, I think we're demonstrating at least one way you can come together in real time to address an immediate need, depending on what that need is. So I think the combination of an incident command structure with regular interaction with the appropriate state agencies and executive branch officials, would be great. And yes, Sarah, yes, it would be helpful to have some data regarding admission. I know that work is underway. Thank you for calling that out. I appreciate that. I'll stop now. Thank you, Jeff and Tim. Thank you, Dr. Fortunati.
Okay, thanks, Carl and Frank. Tammy, I see you have a question. Go ahead.
I just had a point of clarification. So I'm not sure what the recommendation is. It sounds like, Carl, you're asking for, I don't know, recognition or credit or something. But is there something that you would otherwise need people to do? Or I'm sorry, I apologize. I'm just not clear on what the recommendation is.
Yeah, I apologize too. And I guess my sort of metaphor we're trying to create a set of tools in a box in order to address a problem. One of the tools that should be in that box, is the willingness of the affected providers to come together, in ways that are not conventional, in order to address the crisis. So it's not about credit or anything like that. It's about how we as a system respond to a crisis, in real time. And I think in this instance, and during the pandemic, we've demonstrated that daily comings together and sharing of situations by people who can effectuate need. In this case, the need was too many patients in the Connecticut Children's Emergency Department with children with behavioral health disorders, and how to best get them the treatment they need, and having the related entities that provide similar types of care rally to address that crisis is what we're talking about. So to me, it's just a tool that ought to be in the box as we report back to the board about things the state and providers can do to address this and future crises in healthcare. Thanks.
I appreciate that. I wonder to the degree to which that work would be aided by like real-time data around capacity. Or if it's really just a human system that you need, where you need people at the table on a call. And it may be a combination, but I wonder to what extent it would be helpful to also have some kind of centralized real-time capacity slot availability data.
I'll just comment in the absence of that tool, and I think of that as sort of the brass ring. We're left with the need to have to come together personally, to share that information. But I agree with you, and there is a DEMA-SPED availability tool. Groups have been talking about this sort of thing. Perhaps this experience is demonstrating the need for us to explore that as an intermediate or longer term solution. Thank you.
So follow-up question for you, Carl, or whomever knows about the mechanism, but I clearly hear your recommendation, just essentially having a standing mechanism in place, or at least a policy and procedure to be able to quickly stand up a critical incident response when you face situations like this. But my question for you is, to what extent were the community-based providers involved in the incident response? Because I think that connection between hospital and community is also important. I just wonder if that was part of the structure.
Well, and because we were addressing an immediate crisis in care with respect to children who needed inpatient psychiatric care, we were sort of addressing that particular, issue first. So, in these moments, as we were trying to figure out how to get these children and adolescents into inpatient psych beds, we sort of stayed focused on that. But Jeff, you're absolutely correct. There's nothing more important than engaging the other community providers, because in some instance, after assessment, we determine that perhaps an inpatient psych placement is not optimal, and there's an intermediate level of care or other level of care that would be more appropriate for that patient. So we need to commit to getting the patient into the right level of care at the right time as quickly as possible.
Okay, thank you for that. Gary, please.
You just hit on one. I would just say, as an EMPS provider, we would love to be a part of that. But also, I just want to congratulate those on the phone and their colleagues. That's a terrific outcome in the face of an utter desperate crisis. I'm amazed at, I don't even know where people get the energy to step up and do that. But I think it's one of the things that is a real asset for Connecticut, is people's willingness to try new things and to come together. But I would equally say, I think, connected to Tammy's comment, that it's unsustainable that it's human people having to, like, every single time to get together. There's so many crises going on at the same time. People on this call are all managing significant issues within their own environment. But even with that, what an amazing outcome that there could be any, that there is an ability to act in that fashion. And I hope that we can learn from that lesson. But also, I would just say that getting all those folks together, this is a very expensive and time-consuming process, this call, and that is even a more time-consuming and expensive process. So I would hope maybe we can learn best practices from that and how to efficiently move it forward. But I just want to say congratulations to all of you that did that. That is just amazing, and is a real tribute to your desire to help people, and your ability to marshal resources where we're in such desperate straits. And I want to thank everyone.
Yeah. Echoing that, it's good to hear that things are moving in the right direction. I know there's still work to do, but it's great to hear that things are at least alleviating to some degree. Any other questions before we move on to the next item on the agenda?
Not a question, but just a heartfelt thank you to everybody who was able to help out, taking patients from Connecticut Children's. And I just agree with everybody else who's already commented on how pretty awesome it was to have everybody pulled together like that. So thank you from me and all of my staff, and especially from the patients who were stuck in our ED.
Great. All right. Thank you, Steve. Jen, are you on the line? I'm looking for you on my grid.
Yep.
Okay, great. So I'll go ahead and turn it over to you if you want to just, I don't know if you have slides that you want to share, that you don't have to, but go ahead and jump in, whatever you have. Thanks.
Sure, no, I'll jump in. So I'm Jennifer Jenks. I'm the new COO over at the Children's Center of Hamden. Prior to coming here in February, I was the Assistant Director of Lifespan Healthcare's Pediatric Behavioral Health Emergency Service. So I feel the pain that you guys have been describing about the ED overflow. Dr. Donis and I had about 26 staff that we moved between 3 different sites. One of those was a hospital ER. So I know how hard and unwieldy it can be to manage the volume when it ebbs and flows. So that's really why I'm here to talk with you today about some of the experiences that went very well for us in Rhode Island. I'll start with data, since you were just touching on that. And I think there's some wonderful software and wonderful things out there, but they do take a tremendous amount of time to get up and running. One of the things that we did, which is so basic, it's almost probably going to make you laugh, but we were required to send an email every single day with our bed availability. So we had 70 inpatient beds, and we had over 125 partial spots in different programs. And we had to report that out by email to one administrative assistant at the Department of Health every day. And then everybody got an email about 2:30 in the afternoon, which some people said was too late, but at least it was real-time information on a daily basis about what kinds of programs could be available to alleviate pressure. So I don't think it has to be extremely complicated. I don't know if anybody has any questions about that particular part. No, okay. The other thing that worked really well for us, we had one dedicated phone line, our Kids Link hotline, which rang in our access center and was answered by our master's level emergency service clinicians. That phone line we used to coordinate care with schools in particular. We asked them to use that phone line to call us when they had children that they had identified as being in crisis, and we would try to help them find a location to send that child versus just calling an ambulance and sending them to the ER. We started off just getting a trickle of phone calls, and last year we got about 6,600 phone calls over the year. So you can imagine we had to hire additional staff to man the phone line. It's available 24/7, which also has its own difficulties. But one of the most important things that we did as part of our work with the schools was to help educate them about how we triage patients. We noticed that when they called us about students, we got very erratic presentations about what was going on for the particular child they were concerned about. So we adopted the Columbia as our suicide screener, and we would go out to the schools and not only train them how to use the Columbia screener, but again, how we, when receiving a call on the Kids Link line, how we think about those youth and how we make decisions about where to send them. It took a little bit of time, but not too long for the schools to really catch on and to feel some relief to have a place that they could call about these youth. It was not as timely for them as calling 911 and having the youth transported by ambulance, but it gave them some assistance. It gave them some a space to kind of consider other options. When the pandemic hit, the governor of Rhode Island approached my boss and asked to commandeer the Kids Link hotline so that she could use it as a central hub to coordinate care for children's mental health around the state. And when she did that, it sort of, between that and the pandemic, everybody sort of came together in a very unusual way and started to really open up and about how they were expanding their services, the kinds of availability they had, and people were working together in really unprecedented ways, which was fantastic. So the care coordination, the foot that we had in the door is there were some organizations that were already doing some education within schools. And so we sort of partnered with those folks rather than creating our new alliances with the schools. And that allowed us to get in sort of faster and create trusting relationships and have them rely on us, again, to be able to help them figure out where kids needed to be seen. One of the hardest things is to manage the volume of evaluations on any given day. I would say the downside of this is that you only have so many staff and so many slots you can evaluate youth, right? And then you have to find other locations. So I don't know here in Connecticut how many folks are doing emergency assessments within the agencies, but it is something that we're looking at doing here at the Children's Center of Hamden. We'd like to create an access center so that we can be a site where youth could come instead of going to a local ER. We can conduct that level of care evaluation and then make a determination about additional services.
Jen, can you just clarify? Hi, by the way, nice to see you. So the phone line, the 24/7 phone line you're describing, that was run by your agency, not a statewide initiative. Is that correct?
That's correct. Mm-hmm.
And then can you also clarify that was just exclusively for schools?
No, and actually we expanded it out to pediatricians, parents. It was originally rolled out years ago. It had been used for mobile crisis. And then when the money dried up for that in Rhode Island, the phone number went away. So we had brought it back about 6 or 7 years ago. Yeah.
And Jen, I just wanted to say, so right at this time, Rhode Island is unfortunately not being able to utilize mobile crisis for kids at this time. Is that correct?
Correct. Yep. There's some small pockets of agencies that are using it. They had specific funding. It's not as well funded as it is here, and it's not as well as.
Right. So for us in Connecticut, you can see how some of those activities in Rhode Island are kind of filling a gap for the mobile crisis that we have here. So we have our robust system here, but there are some things still. I think the piece that I wanted to comment on, the part that we got on the suicide prevention side, which was training schools to administer the CSSR and then being able to be fully knowledgeable about that, comfortable with that, for one. And we're not expecting all school staff again, I don't think Rhode Island did that, but it would be, Connecticut has on the books right now legislation that requires QPR. And so QPR will be a backdrop and has been a backdrop across the state and will continue to grow. It would be great to continue to advocate for schools to have somebody, school social workers, psychologists, to be able to administer the CSSR or maybe the ASQ, as I think CCMC does in their ED. So I just wanted to add that. Other questions or comments?
I think the things that Jen, you just talked about are very logical. Being able to email in availability and get it out to everybody who needs to see it seems like a very smart thing to do. And having a place to call makes a ton of sense, because most time when patients get sent somewhere like the ED or to the police department, it's because they have no one to call. So it really resolves those two big barriers in some sense. They seem, the first one, an email, seems very straightforward and easy to stand up as well.
It really is, and it's so simple. That's why I said it's almost laughable, but it really is very effective. And when I spoke with Tim recently, I let him know we have open beds right now at the Children's Center. And so when there are so many kids waiting for a spot and we have open beds, it seems like a communication needs to happen so that we can solve both problems.
Yeah, I mean, I just speak for myself and our hospital at Yale, but like, our social workers are responsible for so much and knowing so much. They are what you are talking about. They are the email that knows where all the beds are. And but it right now relies on them calling every single place, which we don't always have time to do. So it makes a ton of sense. It could have a huge impact. Yeah.
I just want to comment because in the original plan itself, and it's a long-term goal, is that we have a partial administrative service organization for behavioral health for kids in Connecticut and under the Connecticut Behavioral Health Partnership. But a single point of access or a full care management entity or organization or expanded ASO is partially part of the potential solution. Once you have a single point of access, you could get that efficiency. But in absence of that, there are some things that are opportunities to develop some workarounds. And so appreciate the comments, Jason. I see Mickey.
Hi, good morning, everybody. So Jen, I have a question in terms of kind of, we have a problem in Connecticut with access to various levels of care for particular populations, specifically children with IDD. And so I guess I'm curious in terms of with the daily reporting in of availability, does that include like availability for what that particular entity believes that they are best suited to manage, like different types of clinical problems or challenges or children with intellectual disability? Or is it just, this is how many spots we have and it's basically, kind of, we'll take whoever. See what I'm saying? Right.
Yes.
So we have kids who are stuck because nobody will take them because their IQ is too low, or nobody will take them because they're on the autism spectrum, or, nobody feels comfortable taking a child who is severely aggressive or sexually really reactive. So those are how does that work in Rhode Island?
So there was some specifics given about each bed. So we had child inpatient, we had adolescent inpatient, and then we had a special unit for folks with developmental disabilities. So that was all teased out. Same with our partial programs. We had them for all ages and some specialties. So that was all very carefully listed so that people would know. What you're talking about with some folks not accepting referrals, there was an accountability piece. People in your similar role in Rhode Island, I was the person they called quite often, given my role, to find out why youth weren't accepted and to try and problem solve them in different ways, to kind of minimize how much people were being sort of denied access to care. So there was a sort of a different level of, and you and I can talk about that offline if you want, because I have some thoughts about that.
Okay, I appreciate that.
Yeah, no problem. There are two other things I wanted to mention that were really pivotal in our work. One was using an e-referral platform. We were really very nervous when the first time the governor announced the Kids Link line on a live broadcast. We received a huge influx of calls. And so we got very nervous that we were going to get a huge, overwhelming number of referrals through and not be able to triage effectively. So we went with a e-referral platform called Unite Us. And had great success with working with them, quickly getting onboarded and being able to make referrals for both basic needs as well as mental health and medical needs for the folks that were calling in. So we worked, actually Rhode Island continues the work after I left, but they have both the schools using the Unite Us platform, they have pediatricians using them, mental health agencies, so they are growing that network, and the state has adopted it as their e-referral platform. So that has really, really helped us. What it does, a couple of quick things that it did for us. So we were nervous that if we gave people 3 different numbers for, say, outpatient level of care, we would have no follow-up. We would not be able to tell if the referrals were picked up. But we also were worried about redundancy. So if we gave the same names out to so many different people, you know, was that going to be helpful? So what it does, it works like Uber. So when you send a referral out, as soon as it gets picked up, the other referrals to similar types of agencies drop away. So that's what I mean by redundancy. You don't have that same waste of time, I guess is what it's, you know, so many of us are getting so many referrals. And, you know, when you call them back, they've already been picked up by somebody else. So the Unite Us, I wanted to be sure to mention. And then, you know, the other is, I don't know if this exists here, but sort of a bridge clinic model. So that if somebody is acute, you're nervous about sending them home from an emergency department, but they really don't need to stay in a medical bed, being able to offer 2 to 3 clinical contacts and a medication management contact to bridge them between the crisis and when the treatment is ready to begin. When that spot becomes available. So that's something that we're also looking into starting as soon as possible.
Let me just turn it over to Selma. I think she had a question.
Not a question, more of a comment. I just want to make sure that while we're talking about the bottlenecks that we're experiencing, that we also make sure that we're not forgetting what the admission process looks like. My experience has been getting youth from one scenario to a private bed is a really cumbersome process. And if we can't clean that process up, it's going to continue to slow down the movement. So I just want to make sure that we're paying attention to what that admission process looks like to get a youth into.
And I just want to clarify, because Jen also mentioned you have 9 open beds today. Correct?
At the Children's Center, yeah.
PRTF.
Correct.
Yeah. So I just reading the chat box, we have almost 40 kids stuck in EDs today. And I would be surprised if none of them could benefit from PRTF. I could be wrong about that. So maybe the docs in the EDs can speak to that. And I see a number of hands up. I think Frank was next, and I think then Steve and then Gary.
I just wanted to comment to respond to some of the comments Mickey said about, you know, sometimes, you know, adding more description about what's available and the kind of child that a unit could take. And that's essentially what I observed happening on these calls with the Connecticut Children's, is that previously, and to Selma's point, you know, there would be a referral fax and be 30 or 40 pages of information on one child, but, you know, 20 kids waiting, and what would be sent is the one child who's maybe nonverbal autistic or aggressive, and a hospital might say no. But the reason they're saying no to that is because often, not that they can't handle that child by themselves, but because that child might be the 5th or 6th child on a unit, and their staffing is already maxed out. And being able to go deeper to look at all of the kids that are, to try and put a kid in a bed that the unit would be able to take. Our units, whenever we have this happen and we can't manage a child like Mickey was describing, it's not because we can't manage that child. It's because we can't manage 5 of those kids at the same time on a unit. And that's why I think the comment about digging deeper into some of these referrals is really critical, not just looking at, not every bed is a bed. We have to match the patient to the bed that's available.
Gary,
Steve,
go,
or whatever
yeah,
the
Gary,
order was.
Gary,
Sorry.
if you want to go next, go ahead, and then Steve. Gary, you're on mute.
I was going to let Steve go first. if he
Oh,
wants
okay,
to.
sorry. Go ahead. Go ahead, Steve.
All right, thanks. I just wanted to comment and then ask Jen if about that system. So there are states, I know for a fact that Georgia has a system similar to what Jen just described about posting beds and in real time, but they also include sort of a universal referral system that is basically posting the patients you think need inpatient beds so that everybody can see it. So every inpatient unit can see it and every ED can see it. And I find that very compelling in the sense that then it holds all of us accountable. All right. And so if there's a child stuck at Yale and he's been there for 5 days, and I have a similar child in my ED, just because my social worker is quick to grab a bed that opens doesn't mean that's the right thing for those kids. So there should be some parity there across institutions for kids as well, and also would allow us to track what kids are being stuck for the longest periods of time. And I think also addresses Frank's point that, a unit outside of my, all units are outside of our institution, but a unit that says, hey, we're really packed, but oh, wow, that kid that just popped up on the referral board looks like he would be a good fit for our milieu or whatever you want to describe it as. So we can at least relieve that patient. So that's something, and I wanted to just ask Jen if that was included in that system you just described.
Yes, we always listed our boarders with the date that they were evaluated. So we always went by time that they were waiting. That's incredibly important. We did not reveal that information, that the specifics of cases and names was not revealed, but there was internally, we did have a list.
Yeah, Steve, I just want to comment too. So that name of that program in Georgia is Behavioral Link, and there's another one similar called Open Beds, and that began with beds, but it's for all services now. And it's similar to Unite Us. They just go at the issue from different perspectives, and we have money in the budget right now to explore all those and other technologies for Connecticut. So, and it is one of the technologies that could be very beneficial to again an organized system.
How fast can you explore that and get it started?
Well, from what I understand, I don't know if the Hospital Association can speak to it, but I think Unite Us, the nationwide one, Unite Us Connecticut, is already here. And I think a lot of hospitals already have it. I think they're using it in different areas. And I think it's also been chosen for the Inc. project in New Haven. So there may be something that we build off much more rapidly, but we do have an intent to take a look at the landscape of the technology. So, but there's a possibility we could get it into play pretty quickly.
I check it almost every week, and there are agencies joining pretty rapidly. I've been very impressed actually with how quickly it's growing, and the biggest users are the hospitals. I have noticed, I think it's the care planners that are using it the most.
Thank you, Tim. I posted an update in the chat.
Yeah, so that I was just going to say that too, Carl. Thank you. There's a summary of Unite Us. It is an initiative of Connecticut Hospital Association, and the platform is under development. Let's go to Sarah Egan first. Gary, your hand is up. Did you want to say something again? Okay, so we'll go to, sorry. I realize now I just skipped you. So let's go to Gary first and then Sarah. Thanks.
So to Mickey's point, my experience is that the admission process is incredibly nuanced and complicated by the fact that the beds are not spread equally across Connecticut at all. And equally that obviously parent choice and family participation is important. And so you, like I'll just say Northwestern Connecticut, there's either no beds or maybe a couple beds. And so, especially as it relates to the Medicaid population, you want to hopefully have kids be near where their families are so that they could participate. But I think that we're hitting on a key point, which is that organizing, as Carl pointed out, organizing our resources, even on an ad hoc basis, can lead to efficiencies that can help us in the short run. Among them, I would say, I feel like there's underutilized. Connecticut, if it chose to, could pivot care coordination, the stuff that's funded by DCF, and say, we want the care coordinators to help us get all these kids out of the emergency room now. We could say we want the residential treatment centers in Connecticut, and there are residential treatment centers in Connecticut that are still functional, to open up beds. So there are these things. And once again, I don't want to put Tim on the spot about things that are behind the scenes. But I think that we're hitting on some key things. But for me, one of the key things is the information. And so the concept of there being a transparent, organized way of doing this and understanding it. So within our organization, the kids that we know of that are in our region that are stuck in emergency rooms, we look at every single day, and we have that, what Jennifer was talking, we have a little profile of them. And, sometimes it'll say something like, referred to X hospital, been there 4 times, not a good fit. Or could be parent refuses to go to this hospital, had a terrible experience, wants to go to this hospital, and wants to wait. So I think on an ad hoc basis, we're putting these things together, but it would obviously much more efficient to look at Connecticut, a relatively small state, cohesively. So I appreciate the discussions. Thank you.
Thanks.
Thank you, Gary.
Sarah Egan.
Yeah, thanks. I think this discussion is really important. I just wanted to piggyback on some of my comments in the chat, that looking at how kids get stuck in inpatient too, right? And so I just thinking about, we need to have data also in real time on, or regularly updated about what the backlog is at the inpatient, how many kids are stuck for how long, who, why, what are they waiting for, to inform those throughput issues, right? I mean, these are the kids that our office hears about regularly, right? Mickey and I are talking about a child yesterday, young, right? Under 13, suicidality, in and out because of hospitals, because when she gets discharged, she doesn't have anything, right? So that's just not stuck. And then other kids who get stuck because they don't have anything. So as we're thinking about our data dashboards that we need from the ED, I think we also need to be looking at those inpatients, because I think probably most people on the call, not everybody, would agree that when we need the inpatient beds, that's not where kids are going to be getting better, right? They're going to be getting better out in the community and maybe get stabilized inpatient. I mean, I hope I didn't say that in a way that offends anybody, but the inpatient is a necessity, but for stabilization and assessment, but it's the connection to the community-based services. So anyway, I just wanted to piggyback on that, but and hope that we're going to also have a little time today to talk about next steps for our systemic recommendations for throughput. That's it. Thanks, Jeff.
Thank you. Jason?
Wanted to comment on what Sarah said. So I agree. I think that we put a lot of focus on EDs. I think it's important that we do. People being stuck in the ED is a terrible thing. I'll speak to our own experience at Yale, is that we have an inpatient flow issue where we can't get out the people that don't need to be there anymore. They need to go to a lower level of care, and that doesn't necessarily have availability. If we had that type of flow, we wouldn't have any kids in our ED. I could almost guarantee you that is truly a big issue. I think the other aspect to what Sarah was commenting is 100% correct, is those that we want to send home, we don't always, and I've said this before, we don't always have that availability, that 1 to 7 day, get them into a program. And so we end up admitting them, utilizing an inpatient bed that doesn't need to be utilized. I really think a short-term focus needs to be on taking a service that exists and being able to utilize it for that 1 to 7 day touch base in home. We've talked about this before, not creating something new, but being able to do that. And then Someone else commented on care coordination. If there's care coordination that could help be reallocated to find places for kids stuck in inpatient units too, it'll free up inpatient unit beds. Perhaps we need more beds. I'm not going to be the scientist that tells you that, but I think that if we really are able to free up the beds that are being used that don't need to be used, we might be in a whole nother place to really use what we have already.
So I just want to interject here, Jeff. So we'll get to Frank's question, but we do want to get to some of the recommendations that we did send out to you and just take a moment to kind of highlight them. We do want to put forth the many suggestions that have come forth from this group already. As I said, we're touching upon them now again and sign going. So we have a handful of recommendations to prevent youth from getting to an ED. We have a handful of recommendations to get kids out of an ED. We have a handful of recommendations to get kids out of inpatient and
into inpatient.
Into and out of, yes, both of those. And finally, there's some policy recommendations. So let's go to Frank and then Sarah, and then we'll go from there to start to look at least some of the recommendations to date. Frank?
Just a comment. I mean, psychiatric beds, these things are interconnected. I think at Yale New Haven, we're the only hospital I know of in the state that flexes our beds. So we will put 16 and 17-year-olds on an adult unit, what we call a transitional age youth unit for, kids 16 to 17 to 25. And we do that flexing this time of year. And we've done that since 2016, I think successfully, so that we can get kids out of our EDs. But now we're at a crisis point, and the interconnectedness is with adults. We have 36 ED beds in Yale New Haven dedicated to 16 and older. We haven't seen a census of 36 in months. Today it's 59 in Yale New Haven, and I can't recall something like 35 or 40 of them waiting for an inpatient bed, adults. So there's an interconnectedness, and we could flex more and put more of the 17-year-olds on this transitional age youth unit and help. But then I just have more adults backing up and overflowing on the medical ED side. And I think we have to recognize that there is this interconnectedness. I'm a child and adolescent psychiatrist. I hate seeing kids in the ED, but I'm also responsible for the adults in our system. And you touch one thing, other things occur. And I just want us to have sight on that. We could easily try and flex and get more kids in, but then I'll just have more and more adults taking up a acute medical bed in the ED waiting for a hospitalization.
Yeah, I think it's an important point, Frank. Appreciate that. I think we, in our recommendations, are trying to think about this as a cohesive system and not put all our eggs in. It's not just about adding inpatient beds. It's part of the solution, but I think you have to address things in multiple levels of care, including thinking about how the impacts on movements in the child system might impact the adult system. So thank you for that. Sarah, go ahead. This is a last comment from Sarah, and then we'll spend the last few minutes reviewing the activity. Go ahead, please.
Okay, just to maybe reflect back, as of this very moment, just between our two largest EDs, it sounds like we have 39 youth who are waiting for inpatient care, and who knows how many more will come in today or tomorrow. Not all of these kids are going to end up going inpatient. They either stabilize or whatever it is that happens. A lot of these kids are going to be coming back into the community. I would like to say that there have been several comments about mobile crisis either being the thing that's described or having capacity right now to be able to be helpful. In the last week, I mean, I oversee one of the teams. There's lots of people on the call who are involved with mobile crisis. We've had 5 referrals. So we've had the 5. We did offer a lot of triaging options last week, and that just didn't pan out. Another thing that we offered last week that was, to Mickey's comment, I think a little bit, is that and Jen said it herself, there is untapped capacity around the state. So it happens to be that we have a specialized program for DDS youth who have an urgent need to be able to be served sort of right now. And so I guess I'm just reflecting, there is untapped capacity. The issue is much bigger than just the community-based services, but we are there to be helpful, and hopefully we can be helpful.
Thank you, Sarah. I think that just highlights the need for improved connection and relationships and collaboration between hospital-based programs and community-based programs. I think we all have heard and seen moments of gaps where there seems to be still a disconnect. So I think there is some room for that. While we're pivoting here, I did see some comments in the chat that I wanted to be able to talk about. I participated in a high-level internal meeting with a number of commissioners yesterday evening. One of the comments that is in the chat is about the DSS procurement. Last night and this morning, I was aware that that is unstuck and is now moving forward. There was, what I understanding, an internal issue with it that got stuck internally, and the commissioners at DP, the commissioner at DPH moved that forward, so it should be coming. I also understand there's movement on some inpatient rates that, again, it's not public, or it's on the way to be public soon, and some other activities that unfortunately we're not able to be transparent about right now, because I appreciate Gary's comments, and my questions last night on this meeting is how much of this can we start to share, and there's some pieces that just need to be take place before that information gets out there. But I just want to say, by similar to kind of Carl's opening response about how the hospitals rallied, the same is true of a number of commissioners and OPM behind the scenes in the last couple of weeks, and that includes the groups that the Hospital Association has been reporting to. So there is lots of movement, and I think we're going to start to see quite a bit of things breaking in the next week or so. So things are moving.
Okay,
Jeff?
let's spend the last few minutes going over something we were kind of chatting back and forth as this meeting was going on. Did not want to interrupt the conversation and discussion. So we had planned to do this activity in the last half of the meeting, but what we're going to do instead is at least prep you for something we're going to email out to this group to participate in. So we are going to try to do a live survey as going through a number of recommendations that came up during the last meeting. But what we'll do instead is we'll take today's conversation, we'll update these not these slides, but we'll update the survey with other ideas and recommendations that came up today. And then we will email you all out a link to that survey to prioritize recommendations, just to give us a sense of the universe of ideas that have been raised over the last couple of weeks. What are the highest priorities for you in each of these areas? So let me just scroll through what I have, keeping in mind that what you're about to see doesn't include discussion from today, but we will be updating that before it goes out. So the areas we want to, and Tim and others touched on this point just a few minutes ago, we want to touch on recommendations in multiple areas that impact flow at different points in the system. So we have a few recommendations about preventing or diverting unnecessary ED visits for behavioral health, and that's primarily for those youth who are not in need of ED or inpatient levels of care. A second area is recommendations for improving discharge from the emergency department to community-based care. Again, this is primarily for kids who are not waiting for an inpatient bed. Third area is facilitating timely inpatient admissions. Fourth is facilitating timely discharges from inpatient hospitalization. This is the issue that Jason and Frank were touching on. And then lastly, a few policy and systems process recommendations that didn't fit neatly into one of those other categories. For each, we would welcome any considerations that people have around the feasibility, timeliness, or just overall impact that each of the recommendations would have. And what we'll be doing is sending out a survey, essentially a rank ordering activity, so that you can identify the highest priorities, and then we will share that information with you either at the next week's meeting or sooner if we can get to it. So please keep an eye on your email for that when it comes out. We'll try to turn that around as quickly as possible.
Jeff, I think make sure we show the ratings system, the areas that, but we would like people's response as rapidly as possible, because we would like to deliver these recommendations as people have talked. So what our hope was is that we could rank these according to the way people see these in terms of the shortest, most efficient, and best return on investment. There's a full range of the ways we could rank these, and then at least get this set of recommendations and maybe a couple from today's forward. And as we shared, that would go directly to 12 commissioners, the tri-chairs, and this work group that's meeting last night, which is the same 5 of the same 12 commissioners are facilitating this meeting with OPM. And so those would get out there very rapidly. I reported out to them that this was the work that this group is currently doing and that we pivoted. And this was our second meeting, and we were moving as rapidly as we can to get them these recommendations to them. So they're also aware and are hoping to receive them. So.
Okay. Tim, did you want me to, it sounded like you wanted me to talk a little bit more about how the survey will be structured.
Yeah, the last slide, I think, shows kind of the areas that you were, yeah.
Okay. So yeah, as you look at each of those recommendations, as Tim said, we'll be asking you to think about each of them in terms of how feasible they would be. So what resources would be needed to implement that recommendation? What will it cost? And is there political will to get it done? Timeliness is pretty self-explanatory. How long will it take to implement that recommendation, and how long will it take to see an actual impact on the issue? And then the impact category is how many youth could be affected by that recommendation? How likely is that recommendation to lead to an improvement in outcomes, and how likely is it to result in an improvement in overall system functioning? So that just kind of gives you a sense about what you'll receive. If you get the survey and you have questions about what you're looking at, please let us know. Actually, we have a couple of minutes if there's some things that people really want to be part of the ranking process. I see Sarah's hand is up. I don't know if that's an old one or if you had a new comment, Sarah. Go ahead.
I do, and it's really a process thing, because I think that, and I just put it in the chat, that I don't think it's enough to send the recommendations to the to agency leadership and OPM. I think they also have to go to chairs and ranking members of the relevant legislative committees, because those folks are all weighing in too. They're all hearing the same things. They're, I'm sure, calling DCF, they're calling us. I anticipate potentially public hearings to be scheduled before the session. And then, of course, you know, some of these recommendations will need legislative support and appropriation. So if there's a set of recommendations around urgent actions, I think that they need to also go to the legislative branch.
Yeah, so thank you, Sarah. And then Jeff, there's also a comment from Frank in there. Could you review, after I respond back to Sarah, the process by which CHDI will do this? And I think it's a question, it might be helpful to also send this PowerPoint. So is there a PowerPoint, or is there a survey and the PowerPoint is the question, I guess. Sarah, yeah, so I believe all these commissioners have their legislative liaisons as a part of this. So I think that would probably just flow pretty quickly. So we will be sure that that's raised. Thank you.
Just reading over the comments. Tammy had a question. Yeah, we're going to try to do as well design an electronic survey as we can with the time we have. The PowerPoint is, the content of the PowerPoint was intended to match what will be in the survey. So if you get the survey, we were hoping to put something up on the screen just to give you a preview through PowerPoint, but instead we'll just update the survey itself, and all the updated information through today's meeting will be included there. So hopefully that answers Frank's question. And Elise responded and said we can send out either or, both of them will be updated. And find timetable for finalizing the recommendations. Did we cover that question, Sarah and Tim?
I thought we were going to be able to get through this today, and thought we could finalize our kind of report by Friday close of business. And so I suggested there was a possibility that we could have it to these groups by early next week. Given we didn't get through that mid to end of next week at the latest, I just think that we're both, Jeff and I are responding to this group's desire for moving this rapidly. And I think all these groups waiting for our recommendations are desiring this information yesterday, if you will. I mean, that's what I heard loud and clear. There is some other groups who are also putting forth recommendations. And oh, by the way, just so you're familiar, many of them are very similar and reflect very much of these. And by the way, what's not here is some of all the things that we've talked about, which will also be included: rate increases across the acute and intermediate levels of care, a lot of those kind workforce development issues, recruitment issues, tuition reimbursements. All those are part of this whole thing, but we're really focused on these short-term things for this this actual particular work this last week, this week, and again, we'll be meeting again next week. So hopefully by next week, we'll have at least put forward this group of recommendations, and then we to pivot next week as we need to.
So it's 10 o'clock. I will attempt to answer Sarah Becker's question real quickly. So just to be very clear, what Tim just said, we're going to focus on the short-term solution recommendations. That's what is going to be sent out to you in the form of this survey. It's going to be the things that have come up in this work group for short-term solutions, and we'll do the best we can to design a survey that's going to yield some good information to inform the process. So with that, if there are any things you want to share with Tim or myself, please email us after that. I want to respect everybody's time, so email us if you have anything else, and we will get back to you as soon as we can. Thanks, everybody.
Thank you all.